Good morning, and thank you all for being here. I am Rob Lemansky, the current Quad AI president, and I'm pleased to be here to moderate this panel, which will discuss the United States Pharmacopoeia's proposed changes to the sterile compounding rules, its potential implications on the allergy immunology specialty, and what the Quad AI has done so far about this issue. Today, we will feature a panel of perspectives on the practice and patient access implications of the USP's proposed changes. Each person on our panel will have a few minutes to cover the USP issue from their particular perspective. After that, I will provide a recap of the Quad AI's activities thus far on the USP issue, and then pose some questions to our individual panel members. If there is time at the end, we will invite questions from the audience. To start things off, please allow me to introduce each member of our panel. First, and maybe you can raise your hands, guys and girls, ladies. First, Andrew Murphy, representing the Solo Small Practice Perspective, is with the Asthma, Allergy, and Sinus Center in Westchester, Pennsylvania. He is also chair of the RSL Assembly and the Advocacy Committee. Dr. Aidan Long, representing the Academic Center Perspective, is Associate Professor of Medicine, Harvard Medical Society, and Director of Allergy and Immunology at the Mass General. Dr. Michael Nelson, representing the Military Allergy Perspective, is Professor of Medicine at the Uniformed Services University of the Health Sciences and Director, Medical Education Directorate, U.S. Army Office of the Surgeon General. He is also chair of the Quad AI Immunotherapy, Allergen Standardization, and Diagnostics Committee. Dr. Carrie Sennett, representing the Patient Perspective, is President and CEO of the Asthma and Allergy Foundation of America. Lynn Morrison is with the Washington Health Advocates, and Emily Graham is Vice President of Regulatory Affairs at Heart Health Strategies. At this point, we will go down the line and allow each panel member to speak for a few minutes to cover the USP issue from their perspective. So, do you want to start, Dr. Murphy?
Sure. Thanks, Rob. I think from my perspective, I think that the most important thing is that this is the impact that this is going to have on patient care. We know immunotherapy is an incredibly effective treatment for allergic diseases. It certainly has benefits clearly for patient symptoms, but certainly benefits in terms of saving healthcare dollars. And Linda Cox's data from a couple of years ago in Florida Medicaid populations, immunotherapy clearly had impacts. Improved patient outcomes, patients were healthier, cost of healthcare decreased, patients were out of the emergency room, and overall was a much more greater benefit for patients. That's my main concern, is that once again, the ability of physicians in this country to practice and interfere with patient care continues to grow. It's making it more and more difficult to practice medicine and take care of patients. The concern, one of the other concerns I have is really the lack of data that immunotherapy is not safe, particularly from an infectious point of view, which is one of the positions that the USP has taken. Aidan's going to talk about this a little bit more, I think, but there really is no data that this is not safe from an infectious point of view. And we've been pushed back to USP regarding that, and it's very difficult to get some straight answers from them. But again, I would say, Rob, my concern is that it's the lack of ability to take care of our patients. It's being hampered. It's being pushed in a direction that we don't want it to go. And ultimately, patients are going to suffer. If immunotherapy becomes very difficult or to access or not accessible, it's ultimately our patients who suffer. Venom immunotherapy patients may not have access to a life-saving treatment. Our asthma and allergic rhinitis patients will not have access to immunotherapy, which is clearly disease-modifying and improves their care.
Okay, thank you. Next, Aidan?
Thank you, Rob. I share Drew's concerns about lack of access, and I want to give the perspective of what it would mean to those of us who work in an academic medical center. It's been said if you've seen one academic medical center, you've seen one academic medical center. They all work differently. At my institution, it's a 900-bed teaching hospital. The allergy practice is a physician-run practice. That's to say that all the revenues and expenses run through us, then we're taxed by the institution. But the bottom line is, if there's increased expenses, it comes to us to cover them. As an academic teaching centre, we fall not only under the USP regulation, but also under the regulations of the JCHAO, the Joint Commission for Accreditation of Healthcare Organizations. Because of that, we have the practice at the moment of currently using an inpatient pharmacy to prepare our allergen immunotherapy extracts and dilutions. We have a 12-person practice with about 600 patients on allergen immunotherapy, and the net effect of that is that we end up effectively paying for a full-time pharmacy technician to generate these extracts. I've spoken with our pharmacy about what the impact would be if the current exemption that allergen immunotherapy extracts have with the USP Chapter 797 is removed, and his response was along the following lines. The inpatient pharmacy is currently compliant with USP requirements, even without the exemption. But to implement them for allergy extracts would represent approximately a 3- to 5-fold increased cost to provision of that service, independent of any increased cost associated with the additional purchasing of stock extracts. The net effect of that is it would become a financially non-sustainable practice for us, and we would have to discontinue the provision of allergen immunotherapy. We've already begun to explore what our practice would look like without that if it becomes a reality, but we just could not sustain the increased cost of providing that service if these exemptions were lifted.
Thank you, Aidan. Michael.
Rob, thank you very much, and thanks for highlighting this very important issue and for inviting me specifically. I sit here before you in uniform, but it's important for me to give my disclaimer, which is indeed anything that I say really is my own opinion and not that of the Department of Defense or the organizations I represent. Having said that, it's a distinct privilege to wake up every day and have the opportunity to care for our nation's heroes. I'd like to remind the audience the military healthcare system has a larger mission than what most people give it credit for or understand. So the impact of allergic rhinitis, who would think the military healthcare system would really care at all, right? I mean, we're the picture of walking health. Those who know me know that's not true, but most definitely. But also the fact that allergic rhinitis and asthma are hardly battlefield injuries. But nonetheless, it is substantial morbidity amongst both our active duty populations as well as those that we care for, which are their dependents, as well as the retirees. I'll tell you the TRICARE system, which is our healthcare or HMO organization, is the 4th largest insurer in the United States, military healthcare system. Some of you out there are probably providers in that healthcare system and take care of some of our patients, for which I thank you very much. What I'd like to convince you is that the military healthcare system has a mission to care for a population that looks very much like yours. So it's very important that we have full opportunity and access to life-altering treatments such as immunotherapy, just as you do in your clinical practices. I think later in the conversation I'll get the opportunity to talk more about the impact on the warfighter and his or her readiness in order to perform their mission. It is indeed a realistic importance to have these types of tools that can alter the course of disease and limit the amount of medication that are required in order for them to perform their duties. I will tell you that we've had an enduring commitment to the treatment of allergic rhinitis and asthma with immunotherapy within the military healthcare system. In fact, Valuing standardization and excellence, the United States Army Centralized Allergen Extract Lab was established 40 years ago, in 1976. That entity in Forest Glen, Maryland, now produces more than 30,000 individual allergen immunotherapy prescription sets each year. So it touches or manipulates over 100,000 vials. That organization and members throughout the military have contributed to proper lessons learned in allergen extract preparation in the way of performing workshops, the way of assisting with the practice parameter development, and providing some of the data that have been cited in the response to the USP revisions. I will tell you, again, from my own personal standpoint, but I'm sure shared by other military providers of allergen immunotherapy, that in order to implement these specific recommendations, it really is a showstopper. And I think it will take it off the table for us to revise the facility that produces these 30,000 extracts prescriptions every year. But also the real impact is that the over 400 clinics and points of care service where immunotherapy is provided who will have to adapt their practices. We rely on them to do some of the dilutions that are required for point of care manipulations of gaps in therapy and other things. So that in order to implement those changes, I think it'll be a drastic threat to our ability to provide care. Thank you, Rob.
Okay, thank you, Michael. And Carrie, from a patient perspective.
Thank you, Rob, and good morning. I think it was Oscar Wilde who said, everything has been said, but not everyone has said it. What I have to say, I think, will resonate strongly with what you've already heard, but I come from a different place. I come from a different perspective. I speak to you as the President and CEO of the Asthma and Allergy Foundation of America, AFA, the oldest and largest not-for-profit dedicated to improving the lives of Americans with asthma and allergic disease. I want to thank the Quad AI for the opportunity to speak with you and for their efforts to raise the visibility of the proposed changes to USP 797. AFA is an organization that's committed to fact-based policy. So let me share with you some facts. Fact: more than 60 million Americans suffer from asthma and allergic disease. Fact: for millions of these, allergy is life-limiting. Imagine the worst cold you've ever had. Now imagine it lasts for 3 months, and imagine it happens twice a year. This kind of allergic disease profoundly affects quality of life. It affects workplace productivity, and it affects attendance and learning for affected children. Fact: for those Americans, allergy immunotherapy is life-changing, and it has changed the lives for millions of Americans for the better. Fact: allergy immunotherapy is critical for millions of Americans with allergic asthma, in which it has the potential to change the trajectory of a condition that is not only life-limiting, but is life-threatening. On average, remember, 10 Americans die from asthma every day. Fact: allergy immunotherapy has been administered safely and with great effectiveness to millions and millions of Americans for years and years. Fact: allergists have mixed and delivered compounds specific for individuals using vials of extracts for years and years. Fact: those compounds are delivered in very small volumes intradermally. We're not talking about high-volume infusion, and we're not talking about entering a body cavity. These are the facts, and there is one more. The changes to 797 proposed by the USP will disrupt a process that has been working safely and effectively in a way that poses a real threat to patients. It seems certain that those changes will make it impossible for the practicing allergist to deliver timely immunotherapy to his or her patients, so access to this therapy will almost certainly be constrained. And it seems likely that these changes will increase the cost of delivering allergy immunotherapy, creating additional threats to patient access. At a time when we speak genuinely of our interest in evidence-based medicine and patient-centered care, AFA needs to stand up and say, we believe that the recommendations to change regulations related to allergy immunotherapy do not fully consider the evidence, nor are they centered on the interests of patients. We strongly urge that these changes be rejected. Thank you for the opportunity to bring the patient voice to this panel.
Okay, thank you, Kerry. And next, our two colleagues who do all the wonderful work for us in terms of lobbying efforts on the Hill. The first, Emily.
Hi, good morning. My name is Emily Graham. I'm the Vice President of Regulatory Affairs with Heart Health Strategies and one of the consultants to the Quad AI. We tend to focus all of our efforts on clinical practice issues, quality improvement issues, and the business of medicine and practice management. We have been working with the Quad AI since the draft revised chapter was released in October and continue to try to effect some change both in the regulatory and legislative space.
Hi, I'm Lynn Morrison with Washington Health Advocates, and I've been a consultant to the Quad AI for about 16, 17 years. And we've been doing a lot of work over that time on research and education and health promotion issues. And one of the things that we did starting back in 2011 was try to bring to the attention of the Congress the value of immunotherapy, the need for research to promote utilization. And we got some wonderful help on that from a group of senators led by Senator Cardin and Senator Mikulski, who corresponded with then Secretary of HHS Kathleen Sebelius about the value of immunotherapy. So we have gone back and been working with them to let them know about the concerns about the USP proposal and the devastating impact it would have on the availability of immunotherapy, and they're going to be working closely with us on this going forward.
Okay, I'd like to thank all the panel members for their comments. And at this point, I'm going to provide a recap of the Quad AI's activities thus far on the USP issue. First, we communicated with Quad AI members regarding the USP proposal via December, January, and February practice matters to inform individual engagement in the issue, as well as in January, February, and March e-news. We collaborated with the American College of Allergy, Asthma, and Immunology and its Advocacy Council, the American Rhinologic Society, the American Association of Otolaryngologic Allergy, the American Academy of Otolaryngology, Head and Neck Surgery, and the Allergy and Asthma Network to develop a letter that we sent to the USP that advocates for patient access to allergen immunotherapy. We provided background and additional information on the proposed changes for members to use in developing their own letters to the USP, and communicated with all Quad AI members via special broadcast emails encouraging them to do so. We answered members' requests to facilitate patient engagement in the issue by launching change.org, a petition. The petition has garnered support of more than 15,000 individuals across the country. The petition effort included the launch of the Twitter hashtag #SaveAllergyShots. We recruited lay organizations to submit letters to the USP and to inform their own membership and networks regarding access to care issues. We provided feedback to members on individual comment letters and answered hundreds of phone calls and emails as members prepared their own letters. We pursued American Medical Association engagement to address the proposal from a broader perspective while focusing attention on the extraordinary implications of the proposal for allergen immunotherapy. We educated state medical board staff and leadership to assist with policy development that would encourage further study before replacing the sterile compounding rules. We connected reporters with physicians in their local areas to build public awareness of this issue. And finally, regulatory and congressional advocacy efforts are ongoing, as you heard, and starting to look favorable. Now we'd like to turn our attention back to the panel members to further explore the issues surrounding USP proposed changes to the sterile compounding rules. I have a few specific questions I'd like to ask. The first I'd like to address to Dr. Andrew Murphy. You are the Advocacy Committee Chair for the Quad AI, but you have gone above and beyond what anyone would expect in terms of the amount of time and effort you have poured into this issue. What is it about this issue that is driving the extraordinary personal effort you've put into this effort?
Thanks, Rob. Well, I think I alluded to it before. I mean, I think one of our jobs as physicians, first and foremost, is to be advocate for patients. And this is really a direct patient advocacy issue. That's one part. The other part is that I'm an A&I physician, and I am absolutely dedicated to the improving care of patients with allergic diseases. And to have a non-governmental agency come back and tell me that what I'm doing is wrong and bad and jeopardizing my patients, well, I'm Irish, so I get a little bit mad. I get a little passionate about that. I look at Aidan because Aidan's really Irish. I'm a generation or two away from being from the Emerald Isle. But, we're all facing pressure these days, and I think one of the biggest concerns I have about just medical care in general is that we're being told how to practice. Other organizations, other entities, other people are telling us what to do. Whether it's how we document our notes, whether it's how we're doing quality medicine, or whether we're being told that we're doing bad medicine and putting patients at risk. I remember back to medical school when I graduated, and there was that thing we took was called the Hippocratic Oath. And I think most of us, if you really go back and read that and think about it, our job is to take care of patients. And I don't think any of us here or anywhere in this country are purposely putting patients at risk just because we want to or just because we want to make a buck. And that really drives me up a wall when some of the implied conversations from the entities that we've talked to is that this is just about us making money. It's not. If I wanted to make money, I would have gone to Wall Street. This is not an industry where you're going to walk out and make a couple $1 million and retire in 10 years. I think all of us are here for patients. We're here to take care of patients. We're here to improve patients' lives. And I think it's time we step up and start defending ourselves. And I think through the past several months, I'm convinced that grassroots activation and grassroots intervention from multiple different areas, you'll hear more from Emily and Lynn in a little bit, and Mike as well, that this has broad impacts. This isn't just about me in solo practice in Westchester, Pennsylvania. This is about training programs and educating our fellows about immunotherapy. This is about our military being able to do their job. This is about our researchers being able to do research and understand immunotherapy, how it's effective, how it's going to take care of patients, how it's going to improve patient care. And it's about patient access to care. If Aidan and Mike alluded to a little bit, but if we have to go to third-party vendors to obtain immunotherapy, my sort of little analysis, talking to a few companies, we're talking about a 400% or 500% increase in cost for immunotherapy, which gets put on the patient immediately because we can't bill for it. And oh, by the way, there's these things called $6,000 deductibles that people have now, and they're not going to they're not going to have it. It's going to be very limited access. So I think I'll stop now because I'll keep going and get really mad.
Okay. Now, one for Aidan. As the various organizations were putting together our joint letter to USP, expressing our varied concerns on the proposal, you undertook a review of electronic medical record data at your institute to explore whether there were any reports of infectious complications from allergen immunotherapy. Can you tell us what the results of that analysis showed?
Yes, Rob, thanks. So I work at Massachusetts General Hospital, which is part of Partners Healthcare, the largest integrated healthcare system in eastern Massachusetts. And I thought we might have an opportunity to bring some information to bear on the issue of safety. So along with my colleagues who deserve credit, Dr. Diana Belekian Alina Banerjee, Kim Blumenthal, and Carlos Camargo, we undertook a survey of our electronic records for the last 10 years, ending in November 2015, to identify every incidence of administration of allergen immunotherapy, and then in those patients to see if anywhere within the healthcare system there had been a documented billing for either soft tissue skin infection or septicemia. We identified 3,800 patients, 136,000 individual allergen immunotherapy injections, and about 122 incidents of infection, 1/3 of which were soft tissue infections and 2/3 of which were systemic infections, according to the billing code. We then individually looked at those patient records to determine whether there was any reasonable link between the administration of the allergen immunotherapy and the documented infection. And these were reviewed by physicians in our practice, and we couldn't identify a single incident of attributable infection to the large number of immunotherapy extracts. So in 2 large teaching hospitals, in an integrated healthcare system, over 10 years with 136,000 injections, we couldn't find a problem with infection, which I think brings to bear on the safety of the current practice of allergen immunotherapy.
Great, thank you. And now one for Emily. You've communicated with USP staff in regards to the process they may be undertaking in following up on this proposal. What do you anticipate for a timeline, and what next steps might be, assuming the USP does move forward with the proposed changes?
Sure. So we've absolutely had conversations with USP staff. As a matter of fact, within days after the release of the draft chapter, we immediately contacted USP staff who are responsible for helping the Compounding Expert Committee and the Microbiology Expert Committee, which joined together to develop these revised guidelines, if you will. And one of the things that we learned is that because this is a high-impact chapter, it is very possible that we will see some additional revisions come forward. I do believe that all of the efforts that from Quad AI and from other collaborating organizations are having a significant impact, which would mean that the draft would probably be released again, and we may see a compromise. Not 100% sure, but I think that's what we're hoping for. But other chapters, including Chapter 800, which addresses hazardous drugs that are handled in practices, that actually went through 3 drafts. So the timeline could be pushed out pretty far out if this happens for this chapter as well. In addition to that, there have been a number of conversations that we've had with Capitol Hill staff, with the Senate Help Committee and others that have yielded some good information. These groups have pushed for USP to have conversations with the allergy and asthma community on this issue, and we're hoping that that's making a significant impact as well. In terms of timeline, again, it remains to be seen whether or not we're going to see some additional draft proposals come out from the USP. But if not, I think the earliest we would see anything finalized would be sometime middle to late 2017. And of course, that would just be for their guidelines. It's not clear how quickly there would be some guidance from the FDA in terms of adoption of those by clinical practices.
Okay, thank you, Emily. And now back to this table. Michael, an allergist who is a retired member of the armed forces raised a concern that the proposed changes could make it difficult for active duty service members to access allergen immunotherapy in the field. Do you see potential challenges arising for our military from this proposal?
Great question, Rob. Let me start with the story, I guess. And I'll remind you that TRICARE is the 4th largest HMO in the United States. has 9 million beneficiaries. Of those, 1.8 are active duty service members throughout the 3 services. So the implication is that they must be cared for and have full access, free immunotherapy. Well, they do have free health care, but we do see this as a significant threat to the access to care for immunotherapy. And I'll give you an allegory or story as to how that might occur. So think of a graduate from high school, 18-year-old, wanting nothing more than an education in a great undergraduate institution and the ability to serve his or her country. They pursue an ROTC scholarship with the intent of completing it at one of our fine universities in the country, receiving some initial training in the military, and then going on to serve afterwards. Wants to be a pilot, studies engineering in school, and does extremely well. Well, the induction standards and the competition for a scholarship requires you to be relatively healthy. So clearly those with significant asthma already on immunotherapy or not requiring it wouldn't get scholarship or the ability to proceed along that pathway. But the bulk of these individuals often develop this type of disease during their active duty service or training and beyond. So after substantial investments in their education, in their training to do the job so that they can execute their mission within the military, we have to have resources and the ability to treat these individuals effectively and get a return on that investment, and more importantly, contribute to the health care of the individual involved or contracting these diseases during active duty service. Immunotherapy has been an important part and an important tool that we may often reach for it a lot earlier in the course of a disease than you might see in the civilian sector. So I gave the example of this being a pilot interested. So pilots, as you know, have restrictions on what they can take when they're flying their aircraft. Immunotherapy gives them that opportunity to change the course of their disease and perhaps relieve them of the need to take medications that may interfere with their ability to fly. There are examples like this all over the military amongst our active duty service population, and this is an important tool in our armamentarium as military healthcare providers. And we would like to preserve it. I will tell you that it is impossible to have a military allergist at every treatment facility where we have soldiers, airmen, and Marines. So we often are dependent on the local physicians where these bases occur. So the civilian sector, all of you in the audience, help promote the readiness of our force, both from their own personal standpoint as well as equipping them with the skills to execute their mission in the military. So we are very concerned about access to care. As I hear from my right about individuals perhaps not being able to sustain access to care, this is an important statement. In a time where we should be looking at improving the access to care to immunotherapy, we already have great concerns about our underprivileged having access to this important form of therapy. Adding to that gap and only having the privilege have access to it, including those in uniform, is not in concert with where we need to go as a specialty or this important form of treatment. We will not be able to sustain it even by revising the United States Army Centralized Allergen Extract Lab, which provides extracts to all 3 services. We'll have to do a stand down to reformat that facility to be in complete compliance with the revised provisions in the USP 797 document, which will create a gap in care. And even after that's done, the remote point of service care, as I alluded to earlier, is deeply threatened by these revisions from my personal standpoint. To add on to some of the data that you've collected, this extract lab has been in existence for 40 years. There have been 0 reports of contaminated vials, 0 reports of infection of individuals receiving immunotherapy to any collective knowledge of a military allergist that I'm aware of. We stand on that data. I will tell you that facility also does contaminations or sterility testing, not because they were required to, but as a form of excellence, and has that data to produce to supplement the arguments that this is a safe and effective practice. So your military allergy and the centralized allergen extract lab stands by as a resource to help develop and produce the data that will be required to affect these changes. And I sit here amongst friends, family, and different perspectives to tell you that, yes, military is one perspective where we do need to continue to promote the voice of immunotherapy and not have any threats to access to care. I completely respect the USP 797 and their efforts to consolidate their current guidance in 797, to collapse 3 sterile compounding categories from 3 down to 2 to simplify things. Allergen immunotherapy is that square, and there's some things that you cannot fit in a round hole no matter how much you try and shove it. They found out in 2007 we're different, and we haven't changed in a decade. I think it's extremely important that we continue to promote our different perspectives on this issue until we're heard and preserve that access to immunotherapy for the care of all of our patients, whether they're in uniform or not. Thank you, Rob.
Okay, thank you, Michael. Next, we'll turn to Carrie. The Asthma and Allergy Foundation of America responded very quickly to get information out to your various communities and also to submit comments to the USP on behalf of your members during the open comment period. Can you share with us why this issue resonated with your organization and what your concerns are on behalf of allergy and asthma patients?
Sure, Rob. One of the most important roles that AFA plays is to serve as the voice of people with asthma and allergic disease in the national policy conversations that are shaping and reshaping healthcare. Among the policy issues that are most important to those we serve, and therefore most important to us, are issues that have the potential to limit access to high-quality care. Our board has made it very clear to me that this is one of the areas where we must be most vigilant and most vocal. As I said in my earlier comments, we believe that the changes to USP 797 represent a material threat to access to care which is life-changing and may in some cases even be life-saving. While safety is, of course, a very important issue, we have heard little from patients and frankly have seen nothing in the literature to suggest that there is reason for concern about safety, and Aidan and Michael's comments, I think, reinforce that. So what resonated were 3 things. First and foremost, our concerns about patient access in a setting in which our board has made this a first priority. Second, what we perceive to have been a lack of patient input to the USP process in a setting in which we believe that the patient voice needs to be an important contributor to this kind of policy discussion. Finally, the lack of evidence to provide a rationale for this policy change in a setting in which we as an organization are firmly committed to evidence-based policymaking.
Okay, thank you, Carrie. And finally, Lynn, you have coordinated outreach to the Quad AI members in several states to contact their members of Congress based on specific committee assignments of those senators and representatives. What would you recommend to other Quad AI members who wish to communicate with their elected officials on this issue?
So in an issue like this, where you have a non-governmental to governmental, in the case of FDA, agency taking on an issue, there's sort of multiple elements of it, and of course the important one is what Emily has been talking about in terms of direct communication with the agencies, the involvement of the Quad AI in formulating a position and the comments that were made. The patient involvement has been critical. And then we are basically trying to create a situation in which members of Congress are expressing concern to the Department of Health and Human Services. And probably the best example of how, members of the Quad AI have an impact here would be the fact that, we are working on this letter with Senator Cardin, who got interested in this as a result of a meeting with some Quad AI members. Senator Casey is involved because Dr. Murphy has been into his office. We've built up a greater understanding, I would say, of the value of immunotherapy, so that now that we're coming in talking about this threat, it makes some sense. There's going to be, I think, constant communication with you about what our efforts have entailed, and we obviously want members of Congress expressing as much concern as possible so that the agencies that are thinking about doing this don't see it in the narrow context that we've seen with USP, but look at what is the impact on patients. Is there an impact on Medicare? Is there an impact NIH on their clinical trials and so forth. So when we start working on this letter, there will be opportunities certainly for all of you to be involved in addressing your senators and asking them to be involved. If you already have a relationship with a senator or Senate staff, tremendous opportunity for you to just send a quick email or telling them about the issue and their concern and send them our way, or just contact the Quad AI and let them know of your interest in participating, and so that they can let me know and we can make sure that you're in touch with your senators. There's, your involvement is an essential ingredient of everything that we're trying to do here.
Okay. Thank you, Lynn. I'd like to thank all the panel members, and we do have some time now. If you have some questions that are still in your mind, we'd be happy to address them. If you could come up to one of the microphones and just state your name and your question, that would be great. Now, it's a little hard for me to see out there, so please forgive me if I'm missing somebody, but we'll start at this microphone here.
Hi, I appreciate your panels just coming up here and talking today. I think this is a very critical point and issue for all of us here. I had a couple of quick questions that I wanted to see if I get clarification on. I actually run a sterile compounding pharmacy that we're licensed and accredited in all the states here in the U.S. I used to work for one of our leading allergy manufacturers here for quite a while doing the same thing, so I'm pretty familiar with both in-clinic processes and out of it and vendors and things like that. I appreciate this concern. It's an issue, definitely for all of us, and I share that issue as well. Someone asked me the other day, I must be looking forward to the USP changes. I'm certainly not. I think we've all in this industry really suffered a lot of challenges with some of the things going on in recent years here. My question is, we're looking at options if indeed this does have a huge impact on practices out there. I'm wondering if perhaps some of the vendors that provide treatment sets, I have a hard time understanding that it would be a 4 to 5 times increase in cost if we were looking at all the cost involved with making them in-house type of things. Because I think, from my view, from what I've seen, it may not be quite that much. So just as an option, it might be good to clarify what those issues are, what those costs are, in case this does go through and we're all affected by it. The other question I've had, for many years we provided treatment sets for a lot of the allergy clinics in the country and other practitioners, and they were doing billing on this because of the definition of the CPT code does include formulation and those type of things. So I'd be real curious, or like to know if you guys have some more information on that, why that couldn't be billed under the current CPT code for mixing, because as my understanding of the definition of it, there is some definitions that it would fall under that if you were to purchase it from an outside source.
So, Drew, do you want to take that?
So the first one's easy. 95165 is very clear. That means to be direct physician supervision. You need to be physically present in the building, in the lab, in your office to bill 95165. That came up a couple of years ago where there was some misunderstanding about the interpretation, and I think some of our colleagues got a little bit of trouble with Medicare because they were off-site clinics and compounding was happening in a different facility. So, and most of the commercial carriers I'm aware of file 95165 as well. You're right, there is, I can't remember the code off the top of my head, but there is a non-specific allergy billing code. I think it's 95199, but don't hold me to that one. But that's up to your individual carriers, and most carriers don't reimburse with that code. That may vary from state to state and region to region and carrier to carrier, but I think I'm pretty clear that 95165 you absolutely cannot bill, certainly Medicare. I wouldn't risk it. In terms of the cost issue addressed, I looked at that, and basically, Novitas is my carrier, and Novitas is a major Medicare carrier in the U.S. And if you go on their website, you can find out what the reimbursement is for 95165, which is about $11. And looking at the cost of what, I'm not going to mention companies because I don't want to do that, but there was 2 companies I called up and looked at how they would bill, what they would bill me if I bought the extract from them. It was a 40 to 500% increase in cost from what Medicare would reimburse. So even if you were 9565 was allowed to be billed from an outside facility, I couldn't buy it from somebody else who's charging me 3 times what I would get reimbursed from Medicare. It just wouldn't wouldn't occur. I wouldn't do it. That's just a bad business decision.
Okay, we'll take one over at this microphone.
Yeah, Fred Little from Boston University. Just to Dr. Nelson's point about the change in 797, apart from consolidation and efficiency of the guidelines for compounding, what changed from 2007 when the efforts of all the good people here led to an understanding that there was a square that was different from all the other circles?
So if I understand your question correctly, it's what was it that resonated that allowed them to create that chapter? In brief history, 2007, USP went through another round of revisions. At that time, everything, including the allergen extracts were included. The voice of the same coordinated response that you're seeing in effect now came to the table with the safety record as well as the few published reports of safety. That really is what resonated at that time that allowed them to open their eyes essentially and recognize that we were a little bit different. We're using products that already have a preservative in them. So it's not like NECC where you have the potential of products that don't have a preservative and the risk is understandably much higher. So there was recognition at that time. It does befuddle me personally again why 10 years later, that same data, nothing has changed in the way of new instances of infection or contamination, has now caused them to re-put us back in the basket with everybody else, to be perfectly honest. These new revisions would make it, I think the allergen extracts, and the group can correct me if I'm wrong, put us in the second category.
Yep.
It would require a specific new facility construction, at least for our extract lab, to maintain the ISO category 5, where you need, I guess, less than 3,500 spores and an anteroom in order to produce these things. Our facility currently doesn't have that particular setup. But on top of that, to think about having to do the quarterly training requirements, the glove sampling, the lot release testing that is not a current requirement, we were exempted from as long as we adhered to best practices that we contributed to from our practice parameters that were in place at the time. To now implement all of these really will be a showstopper for a lot of organizations, and I think we will see. Even some of the commercial providers say it's just not worth the squeeze, and then that is going to be a significant threat to access to care. So a lot would have to change both within the military allergy clinic itself in order to prepare or conduct some of these vial manipulations locally, and certainly at some of our current providers.
And just add on to Mike's statement, the other thing is there's a 42-day out date.
Right.
So even if we could do all this stuff and it happened and it was no cost and we could do it, instead of having a 6-month out date or a year out date for your maintenance therapy, it's 42 days with a 2-week restriction period before you can release the vial. So then you'd have 4 weeks to actually do your maintenance dose, which most of us with a new vial back off a half a dose, then build people back up. So essentially, you would never really reach effective immunotherapy dosing, and I can't imagine any patient coming back 3 times a month for 5 years for a shot. I mean, the 6-month buildup is a little bit of work, but once you get that every monthly visit, it's much more palatable. But it's just logistically as well to administer immunotherapy. And oh, by the way, there's that risk of anaphylaxis with new vials, which has clearly been defined from the AIT committee and whatnot. So the real risk, I think, doing this is we're going to put our patients at risk of anaphylaxis for a perceived non-existent risk of potential infection, which has never been documented.
Okay, we'll move over to this microphone.
I commend you for all the work you have been doing, but also we have to, we're living in a stage of evidence-based medicine. So we have to document all the things that you're doing and the ones that, as much as possible, to document that there was no infection related to immunotherapy. And so that will be a big undertaking. And also, we're doing things that are making people living a healthy life. So last week at NYU, the Surgeon General equated health as being happiness. So we have to, and our country is found on the pursuit of happiness. So they are impeding some people's pursuit of their happiness. So we have to also address that all the good things we're doing to ameliorate the people who are suffering from allergy, and also try to educate the public about what we are doing, because a lot of people, unless you're suffering from allergy, they don't understand what allergy is and what allergy immunotherapy does. So we have to use our resources to educate the public about what we are doing and what immunotherapy help them with. So we should sort of like toot our horns to the public.
Okay, thank you very much for your comments. We will certainly keep those in mind. Let's take a question or comment. This one, that microphone.
Yeah, hi, Rich Hatch from Oklahoma City. It seems like you're preaching to the choir here, and it seems like what USP did defies logic. It makes no sense to anybody here. So I'm curious, has USP responded at all to our complaints, and was USP invited to this meeting to make a statement to us?
Well, I think I can answer those. We have tried every way possible to communicate with USP. We've had some communications from them, but we've really had no answers as to what they were thinking when they made these potential recommendations. We are having, fortunately, they have now consented to having a phone conference with us, the college, and the AAOA, and that will occur probably within the next week. So that's very encouraging. At least we can start a dialogue to see what kind of steps we can be taking as we move forward. Over here?
Yes, hi, thank you. I'm Cheryl Bernstein from Ohio. First of all, I want to thank all of you for everything you're doing. I think it's great. I just have a comment and then one question. Back to the comment over here about why I think it happened. I could see it coming in 2008. We were audited by the Ohio State Pharmacy Board. And they came through, they saw our facility and asked questions. And right at the end, the pharmacist was getting ready to leave. She asked me if we do compounding, extract compounding. And I said yes. And she stepped in front of me, very close to my personal space, took her finger in my face and said, "Soon you will not be able to." So I could see this as a runaway train. Back at that time, I've talked to Dr. Nelson about it, and of course, other allergists. I'm married to David Bernstein, and I called him up right away after she left, and he told me everything that was happening with the practice parameters and all the guidelines that the allergists were supposed to do for compounding. And since that time, it's kind of been a train on the wrong path. Just recently, we were able to get the exemption put back in the law for Ohio, because Ohio was one of the states, like Maryland, and I think there were others. I'm not sure of all of the states, but there were several states that were had the exemption taken out where you were not allowed to do compounding. So we just recently got it back. And my question to all of you is, yesterday I found out that the Academy has specific physicians responsible for the different states. So Ohio is in a category with a representative, a physician, and all of us are represented by, I think there's 6 doctors. And if you could send an email or a newsletter of those particular contacts for each person's state, I think that would be helpful. That way, we would be able, as the laws affect your region, your specific area, you can reach out to those physicians who are then in contact with all of you and the lobbying and so forth. I think that might be helpful.
Okay, thank you for your comments. We're definitely taking notes here, and we do have 7 regions with 7 governors who represent the regional, state, and local allergy societies, and we can definitely get that information to them.
Rob, can I just make a comment, Rob?
Sure.
So you hit on a very important issue, and the issue is federal versus state. And that's part of why we're really focusing on the federal issue, because 2012, and Lynn or Emily can correct me, I always get this wrong, when the New England compounding debacle happened, federal legislation because USP is just a standard-setting organization. They're not an enforcement agency. They set standards. So when the New England debacle, New England compounding issue occurred, federal legislation allowed the FDA to incorporate USP into their regulations. And then the FDA now has become the enforcement agency. So federal law trumps state law. So if the state law is less restrictive than the federal law, meaning if this goes through, the federal USP guidelines, they rule. If your state's more restrictive, you're okay. You just can't be less restrictive. As it stands right now, it depends on your state. Some states, state boards of pharmacy, incorporate USP by statute, in which case they just basically say whatever USP says, it applies in the state. Some states do not, so it varies from state to state, and you have to pay attention from state to state. In Pennsylvania, we don't have USP. We have our own guidelines, so we're sort of flying underneath the radar a little bit, but it varies from state to state, and you have to really pay attention. But this is really why we're focusing on the federal level, because if this goes through federally, it doesn't matter what your state does, because the USP rules will be enforced by the FDA, and that's going to trump everything in the state.
Take one from this microphone.
Yes, Michael Rupp from New Mexico. The first question I have is, what's the best way to get our patients involved? And the second question is there a way for the Academy to give us concrete numbers we can use when we speak to senators, local legislators, things like that, as to what it would cost us in the worst case scenario to try to do this in our practices or create these facilities or that sort of thing?
Do you want to comment on that, Lynn or Emily?
Well, in terms of the second part of your question, what we generally have is sort of a 1 or 2 page handout that sort of lays out the issues that we are discussing and the questions that we're raising about this particular proposal. So we could probably make that available on the website. I don't know if that's an option, but it lays out the basic arguments. And of course, on Capitol Hill, we always try to speak English as best we can. And so it lays it out really also in sort of lay terms, and which is, of course, what you should generally use when you're dealing with those folks. What was the second part of the question? It was similar.
I think that was...
patients. Oh, yeah. So the change.org petition, I think, to make that available. And then obviously the patient organization, that have been very involved with us in this is, your patients who are active in those organizations hopefully are already hearing about it. But, we have the information that we're providing to all of you, and the patient groups, I'm sure, can help your patients if they get involved through chapters and that sort of thing.
Okay, one over here.
I'm George Green, the delegate to the AMA for the Academy. We got involved in the compounding issue almost 10 years ago when there was actually a death of an asthmatic that the Mother of Asthmatics group brought to our attention. And we at that time tried to get the FDA to take direct control of this compounding industry, which is basically a interstate industry and very little happened. Then they actually attacked us, or me, very actively. But we actually did end up with getting two compounding companies closed down. Subsequently, FDA still did not take over control of the situation. See, the compounding group is basically, USP is basically a group of pharmacists. And the FDA is not. As you know, we had this debacle with the infusion, intrathecal infusion and the bed infections, and that got them USP in trouble. So they're thrashing about now, coming up with a whole new set of regulations, basically directed at this compounding industry, and we're getting caught in the middle of it. I plan to bring this to the AMA again in June as a new resolution because we really have to get all medicine behind this. I mean, we're too small to really fight these things alone. And this is an issue that really affects medicine, that this USP controls this compounding industry, and they're very close. And we've got to get this under the guidance of FDA. And I think out of this, maybe that'll happen.
Thank you. We'll take a comment here.
Yeah. I'm Carla Davis from Houston, Texas, Baylor College of Medicine, and I just wanted to relay one of the very effective ways our practitioners in Texas have involved patients. When the patient comes for allergy shots, they give them the link to the change.org site. And so while they're waiting, they then go on the site with their mobile phone and register and offer their support. So I just wanted to share that that's a way that's very tangible and practical. You can get your patients to support the change.org petition.
Okay, one comment over here.
Yes, my name is Dr. Betty Miller. I'm an allergist in practice in Northern California in the Daly City, Burlingame, and San Francisco area. I hate to admit it, but I've been in practice for 40 years, and I've given allergy immunotherapy injections for 40 years. And I might add that the guidelines, it took 100 years for the Academy to come out with guidelines for immunotherapy. So number one, I would like to know, when is the decision expected on this problem with the USP? Are we hitting ourselves against the wall because something has already been decided and we're trying to wag the tail as an afterthought? I would like to add that the email that said, oh, you better hurry up and make a comment by January 31st came about 10 days before the deadline. And at that point, we could not get our patients involved. I think it's important that we have lists of not having infections from our immunotherapy injections. Admittedly, there have been deaths in the past, but they've usually been from wrong doses that have nothing to do with the immunotherapy process. I missed part of your talk. Do they feel that diluting out allergens that are made by the scientific supply companies, if we get the sterile mixtures, of course, in the office and diluting them out bottle by bottle for each patient, is that going to be considered compounding? Because the mixtures are done with sterile technique. If it is considered compounding, the specialty of allergy immunotherapy will die. Not every patient comes in weekly for allergy shots. They miss their shots, so they sometimes have to go back a bottle because of safety measures. Well, if we have to put in an order to a scientific supply company for another bottle, do you know how long that takes? It takes another 4 weeks. So not only can the patient go down in half, they'll have to go down to another bottle. And I think that we, as the Academy members, need to educate the pharmacy committee that there is a method of giving immunotherapy. It's been safe for 100 years, and they shouldn't change it.
Well, thank you for your comments. You obviously are very spirited about this, and we appreciate that. The letter that we sent to the USP really covered all of the points that you bring up. As far as communicating with the USP, we have not been able to find a way to be able to do that yet, nor have any of the other organizations. However, we now have a foot in the door. I don't know if you heard us say this before you came or not, but we will be having a phone conference with the USP within probably the next week, along with the college and the American Academy of Otolaryngology, who also do immunotherapy. So we feel encouraged by this, and we'll be able to learn from them what they're thinking and what we can do to change that thinking.
Thank
We'll
you.
take one more comment.
A deadline? Is there?
I'm sorry, we're kind of running out of time. I need to try to get as many as I can here.
Ray Zeiss, Northwestern University, Chicago. Jesse Brown, VA. Mike Nelson, just want to congratulate you on supplying Veterans Administration hospitals, over 40 of them nationally, with high-quality, safe allergen extracts. Don't forget our veterans, and I think this should be part of the conversation, that you supply us with some of the best high-quality, safe extracts in the world, and you've done that over 30 years. And I hope it continues in spite of these stupid regulations. Thank you.
Thanks, Rick.
Okay, one final question, and then we're going to have to wrap it up.
My name is John Cohn. I'm from Philadelphia. I'm actually had 30 years in practice and 3 months now as full-time faculty at Jefferson. So I've seen both sides of this piece. I think I want to thank the group on the stage and the Academy for taking this issue up. Looking around the room, we obviously have two jobs to do. One is to reach out to our membership who are not well represented in this room despite the tremendous effort that you've all been putting out. And then we obviously have to get a better understanding, which I've been trying to get, of what USP is actually thinking. We've heard they've been talked to, our lobbyists have been seeing them, but I'm trying to understand what's going on in their brains. And I think that would be helpful, whether we can come up with collaboration with them and do the kind of data that they would want to demonstrate the safety of our products. But I would hope as we go forward, we can get some of that information. And thank you again for your efforts on our behalf.
Okay, thank you. And I'd like to thank the audience for coming. And we will continue to work as hard and as quickly as we can to get this problem solved. Thank you.